Reminding you, this is Terez Boshra Kamel talking to you about part 2 tuberculosis. In this part we'll speak about the clinical pictures of different pulmonary and extrapulmonary tuberculosis. So signs and symptoms of tuberculosis in children, depending on being latent TB infection, which is asymptomatic disease, pulmonary tuberculosis, or extrapulmonary tuberculosis. Pediatric pulmonary tuberculosis. Tuberculosis should be suspected when a persistent respiratory illness in otherwise healthy individual does not respond to regular antibiotics. So, primary pulmonary tuberculosis with focal lymphadenopathy can be a picture. Progressive pulmonary disease, pleural involvement, reactivation of the pulmonary disease initially occurred. What about primary pulmonary disease? It is small subpleural focus and large hilar lymphadenitis. The patient can only complain of fever, night sweating, anorexia, non-productive cough, failure to thrive, and difficulty of gaining weight. TB can spread to pleura, causing TB pleural effusions. As we see from the X-ray, this is homogeneous opacity, white opacity, rising toward the axilla, and this is the same. So, what is this? This is pleural effusion. If the children does not respond to antibiotics, we will consider TB until proved otherwise. We must investigate against TB. So, it occurs usually in older children. They have chest pain and shortness of breath. Fever usually persists for 14 to 21 days despite of antibiotic therapy. Signs include tachypnea, respiratory distress, dullness of percussion, decreased breath sounds, and occasional features of mediastinal shift. These signs are of any type of pleural effusion. So there is pleural effusion, not responding to antibiotics, consider TB pleural effusion. Usually unilateral in nature. Tuberculous pleural effusion have some characteristics. It is yellow in color, high in protein, reaching up to 2 to 4 grams %, low in glucose, marked increase in white blood cell count. Early it is polymorph nuclear, later on it becomes lymphocytes. They have no mycobacteria. They are smear negative for Zell-Nielsen staining, giving special culture for TB, positive in only 30% and up to 70% of cases. You remember the special cultures for TB? Löwenstein. Yes, Löwenstein culture. Progressive primary TB. So, primary pulmonary TB is the first big clinical picture, can spread causing pleural TB, can spread all over the lung causing progressive primary tuberculosis. Progression of the pulmonary parenchymal component leads to enlargement of the caseous area and may lead to what? Pneumonia, atelectasis, air trapping. The child usually appears very ill with symptoms of fever, cough, malaise, and weight loss. Remember, these symptoms are resistant to regular antibiotics. See, as we see here, he is having a cavity and a cavity, which is reactivation of pulmonary tuberculosis. They have weight loss, fever, cough, and rarely hemoptysis because the eradication of the blood vessels and bronchi. It occurs in older children and adolescents. They have primary TB disease in their infancy, and when their immunity is lowered, they have reactivation of the disease, so they have this cavitary lesion that can cause productive cough and hemoptysis. X-ray or the CT is the diagnostic in such condition. We'll see extensive infiltrate or thick wall cavity, especially in the upper lobe. What about pediatric extrapulmonary tuberculosis? Can be peripheral lymphadenopathy. I told you it is the most common extrapulmonary sign. Can be TB meningitis, can be miliary TB, can be skeletal tuberculosis. Other unusual signs include middle ear, GIT, skin, kidneys, ocular structures. What about tuberculous lymphadenitis? Most common site of extrapulmonary tuberculosis, as I said, infected lymph nodes are firm, non-fluctuant, and non-tender, with non-erythematous overlying skin, as we see in the picture. Spontaneous drainage of the lymph node may occur with caseation and necrosis. It ends by resolution, either disappear, or the caseation can occur with sinus formation and keeping out the caseous maternal up to the skin. This is a dangerous part of tuberculosis, TB meningitis. 5 to 10% of children younger than 2 years have TB meningitis. Non-specific TB meningitis as a complication of extrapulmonary tuberculosis. Non-specific symptoms such as anorexia, weight loss, fever, vomiting, seizures and alteration in the sensorium and consciousness, deterioration of the mental state, coma and death can occur. TB meningitis have got stages to occur. Stage 1, no focal or generalized neurological sign, only non-specific behavioral abnormalities. Stage 2, the child will have nuchal rigidity and positive what's called Brudzinski neck sign. When you are flexing the neck, you will have reflex flexing of the knee. It is called Brudzinski neck sign. Altered deep tendon reflex, exaggerated. Lethargy can occur with cranial nerve pulses. It affects commonly the sixth cranial nerve, and this results in lateral rectus squinted. The child will be squinted. Stage 3, coma, seizures, and abnormal movement can occur. To diagnose TB meningitis, it have got a special characteristic CT picture. It is basal meningitis. See, striking contrast enhancement in the base of the brain. That's why it's common to have sixth cranial nerve palsy. And this thick meningitis will cause secondary hydrocephalus. There is dilatation of the brain ventricles, as we see here. These children have tuberculin test negative. CSF have a special criteria, have got increased cells, mostly lymphocytes from the start, increased protein up to 5,000 milligram per deciliter, 5 grams. They have decreased glucose up to 40 milligram %. CSF culture is usually positive for TB. CT brain can be diagnostic with basal meningitis and secondary hydrocephalus. Remember that hydrocephalus in CT means dilatation of the ventricular system. Okay. What about tuberculomas? Patients with tuberculomas or TB of the brain material can cause TB brain abscess and granuloma formation. It can cause focal neurological signs only of the affected part. This can be diagnosed by CT brain. What about miliary TB? It is a complication of primary tuberculosis. Miliary TB is a term mentioned when large number of tubercle bacilli reach the blood in 2 or more organs. If more than 2 organs are affected, okay, it is called miliary TB. The patient will have low-grade fever, malaise, weight loss, and fatigue. Plus one of the following: lymphadenopathy, hepatosplenomegaly, meningitis, peritonitis, cutaneous affection according to the site of TB reached. Choroidal tuberculosis in the nephron can be present. When we do fundus for the patient, if we do fundus, I can see by fundus examination choroidal tuberculosis. Diagnosed by liver or bone marrow biopsy, I will see the special granuloma of TB disease. Miliary TB can include the lung, can be the primary situation. Respiratory signs may evolve to include tachypnea, cyanosis, and respiratory distress. What about bone or joint tuberculosis? It's a common sign. Vertebrae can be affected in 50% of cases, hip in 15% and knee in 15%. Can result in angulation of the spine with a special deformity called gibbous deformity. The disease is called Bott's disease. Bott's disease means severe kyphosis with destruction of the vertebral bodies secondary to TB of the vertebrae. Cervical spine involvement may occur, resulting in atlantoaxial subluxation and death. So, the next part in tuberculosis lecture, part 3, I will talk about how to diagnose and how to treat tuberculosis. Thank you.